Hi, welcome to Detours Understanding Acquired Brain Injury. Today I want to talk to you about hypoxic ischemic encephalopathy. Now, HIE or hypoxic ischemic encephalopathy is a type of acquired brain injury, but it is non-traumatic acquired brain injury. Now, what I mean about this, and this confuses a lot of people. They assume any kind of brain injury is automatically a traumatic brain injury. And while the event may be traumatizing, it is technically not what is referred to as traumatic brain injury. Traumatic brain injury is when your brain is shaken up, is when it is accelerated or decelerated. So if the brain doesn't move in the incident that causes the damage, it is technically not a traumatic brain injury. It is an acquired brain injury, but it is not traumatic in nature as far as the medical profession defines this. It still is acquired. In other words, you didn't develop with this. This is not a developmental problem, but it is not traumatic in that sense. It is emotionally definitely traumatic, but defining it is important and understanding how it is defined. All right. So, hypoxic ischemic encephalopathy. Now, that's a mouthful, and if you try saying that 5 times fast, you'll trip over your own tongue even without any kind of problem speaking or anything like that. The thing is, we need to talk about the terms that make it up. It's also referred to by a bunch of other names, too. Anoxic brain injury and hypoxic brain injury, things like that. But hypoxic ischemic brain injury, HIE, is a secondary injury also in traumatic brain injury and when it comes to infections and other problems, which is why it's going to be the first one we're going to talk about when it comes to other acquired brain injuries beyond traumatic brain injury. In fact, it is one of the key components of secondary brain injury in traumatic brain injury but it is also in so many of these others. So let's talk about terminology. All right, well, first of all, anoxia. Anoxia simply means a lack of oxygen. Your brain cells need oxygen in order to produce energy. That's why you breathe. You have to breathe, you have to respirate, which is technically part of a cellular process, but you have to breathe in order to run your cells. It's that simple. And lack of oxygen, and oxygen is a key component. Lack of oxygen means no energy for your cells. No energy for your cells, they cease to function and they die. Studies say different amounts of time, but typically within just 3 to 5 minutes, neurons, which are highly sensitive to this, die. There's anoxemia, which is lack of oxygen in the blood, but this usually also implies lack of the nutrients they need, which is even worse because that leads to even further destruction. So some cells that are kind of on the edge of not quite getting enough oxygen, if they're also not getting the glucose that they need, and the brain is a huge energy hog, despite being only a small percentage of the body's entire weight, it takes a large percentage of both the oxygen and the nutrients that are needed and produces a lot of waste. So anoxemia, where you're missing both the oxygen and the nutrients, destroys cells even faster. And then there's the term hypoxia, low oxygen. So maybe your problem isn't that you're not getting any oxygen. Maybe your problem is low oxygen. And there are a lot of causes of this. If you're in an environment where there's not quite enough oxygen to breathe, if you're caving, if you're firefighting, if you smoke enough, you're not getting the oxygen you need because inhaling not oxygen, not air, can cause brain injury. If you've got COVID or some other respiratory problem, that can cause long-term hypoxia, which does brain damage. And that's something we'll talk about later, not in this episode, but in another one, about how COVID does brain damage. And it does for about 1 in 4 Some of the variants, it's even more so. But COVID can do brain injury. All right, that's hypoxia. Hypoxemia, obviously, it's a low oxygen in the blood, and that can be much worse because, again, you're also missing the nutrients you need. So there's that. Okay. One of the major dividers can also be acute or chronic. If you suddenly have a lack of oxygen or low oxygen, that's far more dangerous than chronic. So, especially for low oxygen. So, that plays in there. Chronic hypoxia, your brain can kind of adjust to, but if you suddenly don't have air, yeah, your brain cells don't have any chance to adjust to the environment by preserving energy or anything like that, or by constricting blood vessels or anything like that. If it suddenly just shuts off, much worse and much more serious damage. Okay, so acute anoxia, far more dangerous than like a low level of reduced oxygen. So keep that in mind as we're going along here. I have like some of the definitions and things to make sure I cover stuff. So what are the causes of HIE, hypoxic ischemic encephalopathy? Well, one of the biggest ones is cardiac arrest. Now, cardiac arrest, most people think heart attack. Not the same thing. A so-called heart attack is a myocardial infarction. Infarction means basically, well, cut off of oxygen, nutrition, blood flow, does damage to the heart, and heart muscle starts to die. And so your heart is less efficient. Cardiac arrest is cessation of effective function, basically. So your heart is no longer circulating blood, oxygenated blood, and getting waste away out of your entire body. So your heart may be quivering or beating really too fast to get the oxygen and the nutrients to your brain and to itself and to your lungs and to your liver and everywhere else. But what we're interested in is how cardiac arrest causes brain damage, which should be obvious based on, what I just mentioned, but we'll get into that. Respiratory arrest. Now, this is where your lungs are not functioning, are not delivering oxygen to your circulatory system. So your heart may be okay, but your lungs aren't working right anymore. They have ceased to provide adequate oxygen. Now, of course, if this goes on long enough, then it will convert to cardiac arrest. And you have cardiopulmonary arrest, where your heart and your lungs cease functioning right, because your heart needs oxygen, and if your lungs aren't providing it, and this can come from status asthmaticus. So where you have asthma that your medications aren't working on, or you don't know about it or whatever. So this can lead to cardiopulmonary arrest. Status epilepticus, where you have seizures that one after another, and you cannot relax your muscles enough to breathe. And so you're not getting oxygen. Where you can't use your lungs, you can't get your heart to be, and then that leads eventually to cardiac arrest again. Or even if it's not that bad, you still may be in a severe hypoxic state or end up in an anoxic state to your brain. Then you've got aberrant cardiac rhythms, tachycardia, which tachy meaning fast, cardia, heart, fast heart. So if your heart is beating well over 150 beats a minute, your heart may not be circulating enough oxygen to get to your brain and to your heart. And again, if your heart's not getting enough oxygen, then you have that same problem. Then you can end up in cardiac arrest. Near drowning, or drowning as they're calling it now, which still doesn't make sense to me, but whatever. If you got water in your lungs, you don't have oxygen in your lungs. No oxygen to your brain or your heart. Again, this also affects your blood as well, because you can end up with all kinds of other metabolic complications. And I do want to talk about the effects of drowning as well. So that can be obviously a problem too. Strangulation. In domestic violence, we see this a lot. Obviously, That leads to hypoxia or anoxia, passing out, and lack of oxygen. That's more of a hypoxic state initially, but that can lead to cardiac arrest, respiratory arrest. So lack of oxygen again. Then there's asphyxia. This can be due to either chemical or simple asphyxia, which is being exposed to gases like carbon dioxide or to nitrogen. Now, the thing is, these do not chemically bond with the red blood cells in your circulation. So, if you get oxygen, you'll be all right. It's more complicated with what I'll get to in a second here, but still leads to the same problem. No oxygen getting to your brain, neurons begin to die. With chemical asphyxia, it is where you inhale or absorb something into your bloodstream that binds and blocks hemoglobin, which is 4 proteins and iron that transport oxygen to your brain. You tie these up chemically, and even if you're breathing okay, you still can't transport the oxygen and move the CO2 out. This is where hyperbarics is important, because under the right pressure, you can squeeze the carbon monoxide off the hemoglobin under the right pressure, and at several atmospheres, you can even get oxygen to be carried in the blood independently of hemoglobin. But this you see with firefighters and divers and things like that, where you get bonding that you don't want. So as a treatment for smoke inhalation, because of the carbon monoxide, it has a greater affinity, about 250 times greater than oxygen does. All right. Of course, organ failure. If your kidneys fail, your liver fails, you get production of wastes that interfere with nutrient absorption as well as oxygen to the brain. And, then you get other causes like too hot or too cold in the environment, or you get hypothermia, hyperthermia. That also can cause not only cardiac and respiratory arrest, but interfere with the transport of oxygen and nutrients in the brain, and other things like starvation and many other causes. But these are just some. Okay, so what are we going to focus on specifically? With HIE, today we're going to talk about cardiac arrest specifically. And we're going to be talking later a little bit about Julie, who's one of our hosts who experienced cardiac arrest. And we'll talk a little bit about her story. And because what you see with her, she represents a good recovery. And what doctors mean when they say a good recovery. It's not what you would expect necessarily, but what you might think of when you think of good recovery, but it means something different in the medical community. And it's important to understand what they're talking about. Complete recovery is different. It's not the same as good recovery, and that's not something as often, if you go long enough, that you might expect. So please be aware. All right, so somebody who has cardiac arrest, whose heart ceases circulating blood to their brain, or cannot transport oxygen and nutrients for one of the reasons I mentioned above, about 10% of those people survive cardiac arrest. 10%. So 90% will die. So if a doc says their chances are not good, this is why. Because 90% don't make it. Okay? 90% do not survive. So there's a good reason that they'll be negative. Of those 10%, 80 to 90% make a good recovery. 10% won't. But a good recovery is, as I said, doesn't mean no symptoms. Many, in fact, almost all, have some rather serious symptoms long term. Some severe disabilities that may prevent them from ever working again, that may prevent them from maintaining normal relationships with their families, that may lead to divorce and may lead to them not being able to live independently. But they still get out of the hospital, and maybe they don't need nursing home care where somebody needs to feed or wipe or help them go to the bathroom or help them walk. So that would be considered a good recovery, even if to the survivor it's not. or to their family, it's not a good recovery. It is for the hospital. So keep in mind, when a doctor is talking about good recovery, they're not saying symptom free. They're not even saying that your life won't be radically altered. They're just saying that you're not in the hospital on a vent, or you're not, unconscious in a nursing home. That's really more what they're saying in many of these cases. Okay. Basically, it's out of a coma or vegetative type state. That's a good recovery. Even a minimally conscious state with responsiveness could be considered a good recovery. So please keep that in mind. All right, so 5 minutes of anoxia or anemia, you can pretty well be guaranteed there will be some permanent brain damage, something that will leave you with permanent disabilities that aren't going to go anywhere. Can you learn through rehabilitation and come up with accommodations and strategies? Yes, absolutely. But there definitely will be something. 15 minutes of hypoxia or hypoxemia. So 5 minutes of anoxemia, so no oxygen. So if you have cardiac arrest, cardiac standstill, within 5 minutes of that, there definitely is going to be things wrong. And about 15 minutes of hypoxemia, there will definitely be something wrong. So let's talk about Julie and her experiences. Here's a picture of her. Okay. So Julie, she was running. She's a runner, and she was an actuary for Aetna, had her master's in mathematics at Boston University, and she had a cardiac arrest, and she was running, and her heart stopped. She had an electrical abnormality in her heart, and simply arrested. And it took 10 minutes for them to get her heart started. EMS, somebody performed CPR on her. EMS got her heart restarted. And she said she was in a coma for 30 days, unconscious. And when she woke up, she had, her memory wasn't working, and she had to go through long, arduous rehabilitation. And even today, she needs a lot of supportive care. She ended up divorced. Her husband has majority custody of her only son, but she's doing very well despite all that. I mean, she cares, she's compassionate, but she can't work. She can't she can't do the mathematics she used to. All that kind of stuff. So her life has been very adversely affected. She needs support at home for many things that she does. She'd be considered having major neurocognitive disorder. She's had some personality changes, she said. She hasn't described it that way, but, so it is important to understand how something like this can change your life. But she's adapted well, and she definitely would be considered having a good recovery. She's able to interact, able to socialize. She's a caring, compassionate person. She's able to help make a difference in the lives of other people, despite the many disabilities she has. So, it's like, I still think in the end, and to quote her, yes, she's had a good life. And hopefully many, many more years of, helping people out. So, okay, so let's talk about the neuropathology. A lot of brain injury experts divide HIE into what's called a two-hit model. All right, first, there's the primary injury, when you stop getting oxygen to your brain, or it's low for a long period of time. First thing that happens is, and we've talked about this with traumatic brain injuries, like when it stops, there's that excitotoxicity. When glutamate is released, when excessive glutamate, which is an excitatory neurotransmitter, is released, it causes calcium to be, the sodium potassium gates, they open, and you get calcium streams in large amounts, as well as, the sodium too, and this causes an imbalance in the cell because it's normally used to generate just an action potential, a discharge, and causes the cell to fire. But this much causes, it's too much. It causes toxicity for the cell, causes destruction of the cell, because it also alters essentially the mechanics of how the cell works. I talk about the particulars in secondary injury for traumatic brain injury because this is one of the mechanisms for traumatic brain injury too. And then you get the calcium-mediated injury. You also have, as the cell membranes become unstable, you get what's called phospholipid release of fatty acids, which also change the cell membrane, its permeability, and all kinds of extracellular fluids outside the cell get inside and cause the cell to start coming apart. And the cell dies. And this is, in some cases, immediate. A cell triggers its self-destruct mechanism because it's not functioning right anymore. Or the axons begin to break down. So it can happen fast or slow. Here's of the process. Now, if, this all unfolds, and by the way, all that excess excitation from glutamate and the destruction of the cell triggers other cells nearby to start destroying themselves. The longer this goes on, the more and more cells get destroyed. Again, those of you who saw the video on traumatic brain injury, this should sound very familiar. Now, when they finally get circulation restarted, then starts the second hit, because in this case, you get what's called reperfusion injury. Because even if you get the heart restarted, the circulation, as they mentioned, this is why you're still doing CPR, which is not as efficient as having the heart beat by itself, or even if you get the rhythm back, the heart is still weak and not as effective. So you'll get your reperfusion injury. And so you'll get clots, small clots, which form microscopic clots throughout the brain in the capillary beds, which continue the hypoxic incident. You also will get then things like anemia, so due to damaged red blood cells. So you're now lacking even more oxygen. You also are having the blood-brain barrier breakdown. We talked about this in traumatic brain injury, how then that means that not only microglia, but also some of the phagocytes and other white blood cells come in there and destroy cells that maybe had a chance to heal, but now they don't get a chance to heal, and they'll be destroyed. So even further destruction. So you have edema because of the imbalance of the fluids from neighboring and adjacent cells. You'll get vasogenic edema as well as the cytotoxic. So you get brain swelling, which does further compression and kills even more neurons throughout. And that's a result of that imbalance with cellular contents being spread throughout the brain. And then finally, neurons start necrosis. So they'll start to die off and they'll be consumed. And then other neurons that are injured will basically eat themselves because the lysosomes, which contain the enzymes that do digestion of material that's unwanted, they'll rupture because, that's how they destroy themselves if there's damage. So you got neurons that die off or self-destruct because they get these internal self-destruct signals. And so it leads to widespread damage throughout the brain. What's interesting is you'll often see more gray matter destruction. Unlike in TBI, where you have a lot of diffuse axonal injury, so white matter destruction. Here, from layers 3 to 5, there are 6 layers that make up the cortex for people. There are some areas that are about 4 layers, and then there are transition zones. You'll see more gray matter destruction. Gray matter are basically the computing units of our brains, or the microchips, if you will. The white matter is more like the connectors for the networks. So you'll see destruction of gray matter, and a lot of it throughout the brain. In some cases, you also then get white matter destruction, but it's much less often. Some cases you'll get what's called post-anoxic leukoencephalopathy. That's a mouthful, but in about a third to a quarter of the cases, what happens is the person will start to do better. After they're resuscitated, they'll start to look like, hey, they're doing great. They're starting to talk again. They're starting to move, everything else. And then it's like, hey, wait a minute. Why are they starting to decline? Now, post-anoxic leukoencephalopathy after cardiac arrest, what happens is the white matter starts to degenerate because of lack of input and because the immune system now is attacking what it thinks are cells slated for destruction. And so you also then lose the networking between regions of the brain. So not only do you lose the gray matter, you also then start to lose the white matter. So people with this have even more disabilities. So, so what are the kind of long-term changes that you can expect to see? There are a lot of different debates as to exactly like where we should focus our efforts and what kind of things we should expect to see. Some neuroscience researchers say, well, this attacks the entire brain. And that seems fairly reasonable depending on what kind of, how long and whether it was anoxia or anoxemia, hypoxemia. And others say it's more about watershed areas where two major arteries overlap in those regions. You can find studies that support either one of these, but we do know it affects so many different things. So like sussing those ideas out, man, we're still not clear on that. The watershed areas are the basal ganglia, which kind of ties together the major functions, the deeper areas of the brain. The gray matter are those deeper areas. Cerebral cortex, the hippocampus, and the basal ganglia are areas that are most affected, obviously, on either case. Frontal lobe, of course, globus pallidus, locus ceruleus, these areas are badly affected. The cerebellum, also affected. So gray matter versus white matter. We know about the post-hypoxic leukoencephalopathy, which I just mentioned, and those cortical areas 3, 4, and 5, which are integrative. They're gray matter, but they tie together close by areas, which allow the gray matter to work almost like a microprocessor. Overall, long term, you see general brain atrophy. So the brain will shrink. Risk for seizures is significantly higher. Risk for progressive dementias, that goes up. So risk for Alzheimer's if you have a history, things like that. And damage to your other organs too with cardiac arrest. Liver, kidneys, heart, of course, is at risk. And so, need to assess for progress. So how do we know? How do you know the progress? This is when, your doctors can be kind of glum. How do they know after you've had cardiac arrest? How do they know whether to say, yeah, this person's got a better chance or worse chance? They don't just make it up. There are a couple tests they can do, and you may see them do. So, well, first of all, probably one of the better ways to make this it's an educated guess, because no two brains are alike, as you're well aware, and as I say quite often. First, they look for the brainstem reflexes. So, mainly you're talking about pupils, but there are other ones they can look for, but that's the big one. Do they dilate in response to light? Do they converge? Can they track? You're looking for how they react. Do they react to pain? What is their Glasgow Coma Scale? And if they don't react, that's not a good sign, obviously. Now, doing it immediately is not a very good. No, usually they have to wait and track them over a couple days while this person's in the ICU. Okay, so this unconscious patient in the ICU, That is so typically 72 hours, especially if they're cooling the patient down, which is one of the things we do today. We'll cool them down. We'll talk about that in a moment. Decorticate and decerebrate posturing is actually better than not at all. So if you've seen me talk about it, if their limbs are flexed inward and their feet are pointed inward, that's better than outward, and that's better than no reaction at all to any stimulation, any pain. And verbal response is better than response to pain, obviously, than responding to verbal stimulation is better. There's something called a continuous EEG. And that is where they'll have the patient wired up to an electroencephalogram continuously and be looking. If there are signals like this is much more promising. Or response to stimulation, touch, pain, verbal, you want to see this. However, if you see this is called a burst suppression to stimulation or not. Basically, it's non-epileptic seizures. If you see this, that is a bad sign. All right, it's not universally bad, but only about 3 or 4% of these patients make it. So it's not a good sign. This isn't a good sign either. A flat EEG, definitely not good. But again, there are those people who, despite this, do survive. But the percentage is very small. And those without disabilities, profound disabilities, if they do survive, not good. Yeah. So it's about being realistic. This is called a somatosensory evoked potential. An SSEP, its validity for predicting, it's really hard to say, but it shows a complete circuit from the area being touched all the way to the brain. Lack of the signal, not good, but it isn't necessarily predictive of good either. But combining these things is certainly better than just spitballing and saying, I think. Other signs like this. If the patient does a lot of this, myoclonic jerks, that is definitely not a good sign for prognosis. You can control it, but these little seizures, yeah, that's definitely a problem. Yeah. Yeah. Good signs are fluctuations in vitals when people talk and things like that. So what are the different long-term outcomes from HIE, hypoxic ischemic encephalopathy? It's a long list of things that can happen, even with a good outcome. You can have permanent learning disabilities, specific or general, IQ loss, 5 to 10 points. Speech or language problems with anomia or even understanding it. Dysexecutive syndrome, that's very common. Problems with organization, thinking, planning, understanding the big picture, that kind of stuff. Cognitive processing is often a serious problem. Slowing down with your thinking, things like that. Concrete thinking, having problems with abstraction, knowing that words can mean multiple things and understanding the more remote meaning for it. Loss of the abstract attitude, which basically means you take everything literally as it appears to be instead of understanding double entendre and, like jokes and things, having problems with some of that. Personality changes. More apathetic or more irritable and aggressive, that kind of stuff. Loss of empathy, behavioral changes, impulsive and aggressive, like I said. Emotional changes, neuropsychiatric problems, depression, anxiety, OCD, those are a possibility. Visuospatial and visual deficits, problems recognizing people's faces, prosopagnosia, trouble recognizing objects, motor and coordination problems afterward, tremors, trouble holding things, trouble walking, moving, trouble with bowel and bladder, Sensory deficits, trouble with your vision and hearing afterwards, trouble with, even your sense of smell or touch, things like that. Endocrine problems, new onset diabetes or diabetes insipidus, or things like that. Cardiac and respiratory dysregulation, excessive excitation, neurostorming, increased chance of another acquired brain injury. That's a big problem also. Damage to your peripheral nerves, numbness in your hands and feet, neuropathy. All of these things are not unusual afterwards. Any or all. There are other things too, because this does extensive damage throughout your brain. So what are the kind of things that can be done to try and reduce damage? It's got to be done quickly. So cooling the patient, here's a cooling protocol. And if they do this, you can't do a lot of those tests that I mentioned earlier until 72 hours after they've stopped the drugs and stopped the cooling. 72 hours is the recommended time to test for the continuous EEG changes, the reflexes, to look for, somatosensory evoked potential, because obviously the meds would still affect the patient. The cooling would still affect the patient. So you got to wait till they warm up. They recommend 24 hours of cooling, and then you start to warm them back up. That's current recommendations. For some patients, ECMO, extracorporeal membrane oxygenation. They had talked about this during the COVID crisis, using ECMO, which is basically a heart-lung machine, but used in the ICU and things like that to help oxygenate the heart and the brain. So anti-seizure medication is helpful to prevent worsening damage. And there are drugs to help with their dopamine agonists, the drugs to help with waking up, and NMDA agonists too. But that's a careful balance. But they help with disorders of consciousness, help wake people up afterwards. The research on that is kind of equivocal right now. It's uncertain. There are experimental meds to try and block the excitotoxic cascade, but so far, it's really uncertain and the results aren't great. And lastly, there are experiments with direct neurostimulation and DC stimulation, etc. So, and stem cells. But that so far is good to reduce neuroinflammation, which is a factor in secondary brain injury. It's a factor in all forms of acquired brain injury. So this is a complicated problem. It really is. But hopefully we'll continue to make progress in treating it. And for now, rehabilitation. Rehabilitation is the best treatment afterwards. If you're one of the 10% who survives and is to make a good recovery, rehab is still the best tool. Physical, occupational, cognitive, psychosocial, counseling, therapy, anti-seizure medications to control both seizures and emotional instability, SSRIs, a lot of the same treatment that's used with traumatic brain injury. And so, that's where we stand. And hopefully you found here this to be useful. Please click like and subscribe. Don't forget to hit the bell icon. If you have any questions or comments, please post them below. And our next episode will be something related to that, which is toxic encephalopathy, which is how chemical compounds can cause brain injury. And there are a lot of incidents of that as well, and they are related both to traumatic brain injury as well as hypoxic ischemic encephalopathy as well. Hope you have a good day.